Hello, and welcome to A Healthy Mind. I'm Dr. Cicelina Grosser-Ledbetter, Director of Counseling and Student Development at the University of the District of Columbia, and your host. On today's edition, our issue is behavioral problems and children and teenagers. My guest is Dr. James Blair. Dr. Blair is Chief of the Unit on Affective Cognitive Neuroscience at NIMH. He received a doctoral degree in psychology from University College London in 1993. Following graduation, he was awarded a Wellcome Trust Mental Health Research Fellowship that he held at Medical Research Council Cognitive Development Unit for 3 years. Subsequently, he moved to the Institute of Cognitive Neuroscience, University College London. He joined the NIMH Intramural Research Program in 2002. Dr. Blair's research interest involves understanding the neurocognitive systems involved in human emotions and how these become dysfunctional in mood and anxiety disorders. His clinical focus is in understanding the dysfunction of emotion-related systems in youth with conduct disorder. Welcome, Dr. Blair. Time for me to stop and time for you to talk, because that is a mouthful. And it sounds like we were just talking about how important your work is and how we hope that research informs practice, right? That's what's supposed to happen.
That's certainly how we want to do it.
Right, and so tell us what you do.
Okay, so my principal focus is to understand the nature of conduct disorder, so individuals that show elevated levels of antisocial behavior. It's one of the big problems as a psychiatric diagnosis because it's focused on antisocial behavior, and there are many, many ways, many reasons why somebody might show antisocial behavior.
Tell us what you mean by antisocial behavior.
So aggression. Or aggression would be the sort of prototypical example.
Yeah.
And so you can see that sort of thing from purely social reasons, where that's really outside of but you could still gain a diagnosis, even though there's nothing actually biologically wrong with the individual. There's a problematic environment. And then there are also emotional factors that can put the person at risk for elevated levels of antisocial behavior. And so one of those emotional roots in is the sort of anxiety form, the post-traumatic stress disorder, often associated with neglect or abuse. And that sort of child is typically anxious, and also much more reactive, much more impulsive, much more likely to snap and respond violently.
And you're talking right now primarily about the environmental piece related to
Well, no, actually, so there would be purely environmental, just that, any of us might engage in antisocial behavior if the reward so massively outweighs the cost. If you were told that taking this book from the studio would gain you $100 million,
it's good as gone.
It's good as gone.
Right,
yeah, exactly.
Right.
So there's we can engage in reasoning that would make us do antisocial behavior when the costs, when the gains are so much better than the costs, or at least they are better than the costs. But that's not what that still, in certain circumstances, may get you a diagnosis. But there's nothing wrong with that person.
Is that within the range of what we would call normal?
Well, it's certainly the way that you responded there was a healthy response to the option I gave to you.
Okay.
So even though from a legal side of things it might be awkward,
right.
But from a biological side of things, it was a healthy response.
It was a healthy response. Okay.
But then we've got at least two forms of not healthy situations. One is based around trauma and neglect, and that gives rise to heightened emotional responsiveness. And in fact, we can see with brain imaging that the brain of an individual who's been exposed to these sorts of things, we see heightened response in an area called the amygdala, which is a sort of really quite central region, which is very important for basic emotional responses. And so the individual that's been traumatized or neglected has a heightened response to threat. And the problem with the heightened response to threat is the person is much less likely to freeze, which is what you might do if a threat suddenly walked in the room, and much more likely to explode in a rage response.
I would freeze and explode?
Well, if we had a threat over there that came closer and closer, the first thing you would do would freeze. The second thing you would do would be try and run away, and the last thing you would do would be fight the object.
Okay.
What we can see is in some individuals what looks like's happened is that because of neglect and other factors, the system is so primed up that a low-lying threat that would make you freeze or avoid will make that person lash out. So
I see.
I've seen patients, for example, who, they hear a car horn next to them and start thumping on the car and running after the car because it's really got them an incredibly strong angry response.
Okay, so sort of almost like, I don't know if this is a good example, but what men experience in war.
Well,
is that the
it becomes very complicated with war, and it's not clear how many people actually. Again, the data is not clear.
Yeah,
but
I'm thinking about repeated trauma, and it doesn't have to be war.
Oh, so certainly, there are reports of people coming back from war or other traumas who suddenly explode in rage, and it's a sort of classic sign of post-traumatic stress disorder. And post-traumatic stress disorder is one of the things that you can have together with conduct disorder. And it looks like, indeed, what's gone on is the person's trauma has given rise to this heightened emotional response that makes the person much more likely to explode in aggression.
So with conduct disorder, though, what distinguishes it from PTSD and somebody just responding, or someone who is just acting out? What is?
Well, it's all based. That's really where the problem with the diagnosis lies, because the diagnosis is focused entirely on having done a certain number of antisocial behaviours in the last 3 months. A certain number
forget it. We all qualify.
Well, probably not all of us qualify, but indeed, you do see you can see some extremely high rates.
So it is.
So what my first goal is really to be in a situation where we can actually say that this child has got a different set of problems facing them from this child, who has a different set of problems facing them from this child. This child might be totally and utterly, like you were in the situation with the book. They just did antisocial behavior because it was the best option available to them given their situation. Then we could have this
survival
within the context
of their lives.
Exactly.
It's survival.
It's at least a healthy decision-making response to the adverse conditions they're faced with.
Okay, so it's healthy.
Healthy. There's nothing that doesn't. Yes, it's healthy
I get it.
enough.
Yeah.
And then we've got this other individual who might be the sort of more traumatized route-in with the reactive aggression, and then we've got a third type of individual who's got a very different problem. They're reduced in their emotional responses. So if you saw a crying face or a frightened face or someone in pain, you would show an increase in your amygdala response. You'd be upset about it. You'd probably want to try and help them, but at least you'd be upset about it. This individual doesn't show those emotional responses.
So is that person is that person a sociopath?
The psychopathic traits in the new DSM, there's going to be this introduction of a term called callous unemotional traits.
Callous
and unemotional traits. And that really covers this sort of individual who has reduced guilt, who has reduced empathy, who has to a certain extent reduced anxiety, but certainly reduced guilt and reduced empathy.
How do you do? So they can all exhibit the same outward behavior.
Even though internally
the triggers are different.
Exactly.
The motivators are different.
Exactly. And so the treatments have to be different.
Okay, so that's what I was going to ask you. So the treatments are different.
They ought to be. The problem we're facing now is that because all of this work is relatively recent, in most programs, it's still within the last 10, 15 years.
Oh, wow.
It's relatively recent. Certainly having the biology to back it up is really in the last 5 years. We had clues before. We only done the imaging studies. Me and other people around the world have only really started doing the imaging study since 2008. So it really is quite new. So most treatment programs, at least officially, will be responding to every child in the same way. Partly because, indeed, the clinical assessment tools aren't available. But that hopefully, to a certain extent, that will change, we hope, with DSM, with this introduction of the callous unemotional trait specifier, that will begin to pull out the child who has the more emotional reduced response from the child who has the more emotionally enhanced response. But obviously, really, what we need is we need things that are as precise as possible, so we can really target interventions as precisely as possible for the individual.
Yeah, and so how do you know if your child falls within that normal range? Like everybody's 2-year-old has that past 3-month-old. They're in that category, that 3-month threshold. But how do you know that your child is, you know, just...
Well, there is there's the diagnosis itself,
Yeah.
which is having done a set number of antisocial behaviours in the last 12 months, a set number in the last 3 months. So obviously, if your child's not engaged in any antisocial behaviour, they definitely won't meet criteria. I mean, not
Right.
involved in any sort of contact with
Well, yeah.
But that again, that's it gets
Yeah.
it gets complicated.
Yeah, it does.
But that's one way
Yeah.
of doing it. Then on top of that, I mean, you'll see that there are indications of anxiety that you can see. I mean, a good clinician will be spotting indications of anxiety that will allow you to push in, one way. And these, these callous unemotional traits, you do encounter parents who are deeply concerned about the interactions with their children.
Because they're really pronounced. They're not subtle, because if when you start thinking about it, I'm thinking, okay, which one of my kids has this? Because you can really find that all teenagers or budding teenagers, preteens, you can almost put them in any of these categories, right? That's the danger of being a clinician sometimes. Not that I am, but it makes you think about the normal ranges and what falls within.
It's difficult, actually. I mean, I certainly, when I used to do a lot of interviews in prisons back in the UK, I wouldn't actually be very good at spotting who was the people. Certainly, when I was interacting, like I'm interacting with you,
Yes.
when I was, reading the case notes and generating the official diagnosis, then obviously it was okay. But just on a one-to-one session, in fact, actually, it was really quite difficult indeed. I mean, many times I got it totally wrong.
Really? Why? Because they present really well?
Some of the individuals can present, and also, people can be not very pleasant to interact with. Nothing
Period.
to do with these sorts of problems.
With the disorder.
Yeah, they just they had a bad day, or there's other reasons for like this anxious group, and there's all sorts of reasons that can get you to be not easy to deal with. And so but of course that may be because I'm a bad clinician. I'm not a clinician. I'm only a researcher.
I got you. That's important too. That's important. We need
that could have been a possibility. But other people have told me they've had these difficulties as well.
I see.
But you do, you'll see
Patterns.
on tasks. Yeah, you can start really picking up the differences. So if you're doing computer-based tasks, you'll see problems in recognition of, say, fear in this callous unemotional group. You'll see heightened attention to fear in this emotionally reactive group, and then you'll see just regular responding in that third, typically developing group as well. So you can pick it up that way, and you can pick it up with the imaging. You'll see reduced amygdala responses to the fear or the sadness or the pain of other in that callous unemotional. So how do you test for
this? Are you exposing individuals? How do you?
So that's
what
we're
thinking about brain imaging.
Yeah,
you're thinking about people being traumatized, so that you could see if their brain lights up or.
Well, so what we do is we use functional magnetic resonance imaging at NIMH. The individual.
That's like brain pictures.
That's like brain pictures, exactly. Yeah, no, exactly. What it basically does is it picks up blood flow in the brain, and the idea is that if you're using a bit of your brain more, it will need more blood. And so you can see which areas of the brain are using the most amounts of blood. So it doesn't directly give you
when you're showing images.
Yeah, when you're showing images or getting people to perform tasks, or there's a whole variety of things that you can get them to do. But images is, like faces, but we do a lot of decision-making tasks as well, when people have to try and win money or, learn that certain things are better than other things, and learn how to choose between things successfully.
I see. And so who's most at risk for the cognitive
for these development of these problems? I mean, obviously, there's no doubt about it that trauma is a very significant risk.
I see.
Certainly for that middle group. It may or may not have a role in the development of this other group as well. We don't really know. The last group is a bit more complicated. We know there's a genetic component to that, but we don't know what the...
Remind us again, those three groups.
So the typical group, the healthy group, the group with the trauma type routine,
right.
And then this third group with the callous unemotional traits.
Right.
And that group, we know there's definitely a genetic component, but I mean, there are other environmental factors in there. We don't know how they interact. We don't know what genes are involved. That underlying cause work really needs to be done, because obviously we can begin to have clues about how we can treat that group, who are currently regarded as definitely the most difficult to treat if people actually make a distinction between the groups.
I see.
But obviously, the more that we can understand potentially about the biology that person faces, the more we can help those circuits, in the same way that we can help patients with depression, we can, there's a biological component to depression, we can help them, we can help them through cognitive behavioral therapy, but we can also help them, some individuals, through other forms of treatment. We should be able to do the same thing. Well, the idea is we can do that for this population too.
So how does this group, how do you get, this is certainly, the Callous Unemotional is quite interesting to me. And I wonder how early you can recognize that someone is growing up with a sort of callous unemotional disposition.
So we only really work from children from the age of 10.
Okay.
Now, there are some groups that are working with younger children, and we know that at least from the early teens, we can see that if the individual meets criteria for callous unemotional traits, their developmental trajectory is deeply problematic. They're going to have real problems in the 20s.
Like what?
They're probably there's a much more higher chance they're going to be in jail, much more higher chance they're going to be in jail for doing, really quite unpleasant actions. There's problems in their interpersonal relationships. There's no.
That's if you catch them before intervention.
Well, the intervention work it's not so clear how well we can help this last group.
Oh.
It really becomes, I'm if I want a goal for where my life goes, I would like us to get to a situation where we can really help that last group. Because, we as a society would benefit and they as individuals would benefit.
Absolutely.
It's one of the one of the things we say most about enjoying existence is the attachments that we have with other people.
Right, and those people have trouble forming attachments.
Exactly. Yeah. So they, if we could help them, we would help us, but we'd help them too.
Yeah. And what are some of the other characteristics that we might see? You talked about aggression. Something about triggers or things that might say, oh, okay, this is more than just the kid misbehaving at 10 or 11. This is a little bit deeper.
It really is the lack of guilt, the lack of remorse, the lack of attachments.
Or just for this third group?
For the third group, yeah. I was just talking about the third group.
Yeah, okay.
So for the third group, you're definitely looking for, somebody individual who's isn't very attached. Isn't very emotional about when they've been upset, isn't perhaps even very emotional about, or when they've upset others, isn't very emotional about things that have happened to them. Traumatic event in the household, they may just shrug it off.
What if they're just cool?
Well,
that it's an extreme form.
Yeah, cool in the way we think about it is probably somebody who's very, very good at emotional regulation.
Right.
That's something very different from this. Here, there's no real emotional regulation going on. But you're right. That's always where when you're dealing with a one-to-one, it becomes, especially when you're not able to test things directly.
Yes.
It becomes very difficult to evaluate somebody who really may be incredibly well skilled.
Emotionally regulated.
Yeah, a highly emotionally regulated individual. But at least that person will probably feel guilt if they hurt other people. They may not express it so much, but they probably won't go and do the same thing to that person the next day.
So tell us before we get too far, what is emotionally regulated? If someone is able to emotionally regulate so that people will understand what we're talking about.
So there are different ways of emotional regulation potentially, but one clear way we can emotionally regulate is we can just shift our attention. So if a predator walked into the room now and I just made sure that the only thing I pay attention to is you, I might not get ever, it would be a very uncunning plan, but it would be...
that would be not good.
It would be a very extreme form of emotional regulation. But basically, if we pay our attention to something else, we can often reduce the emotional response to whatever happens to be out there. The more you concentrate on one thing, the less emotional, as long as that's not the emotional thing, the less able you are to get a good response to the emotional stimuli. Then there may be other techniques of emotional regulation as well, but then it gets more complicated.
Because I kind of see it in my mind as just being able to adjust.
Well, exactly. Yeah. So I was giving a specific
No, but
form
yeah,
of adjustment.
yeah,
But yes,
yeah.
no, you're
Being
right.
able to adjust to the environment and kind of what's coming at you.
Yep.
Being able to adjust. So the characteristics. So we talked about the characteristics of those who lack the emotion.
Yep.
What about the other two groups? What are some of the characteristics? You talked about aggression, and we know that when we see aggression, it's very common for the other two groups to see. But oftentimes, by the time we see the aggressive act, everybody goes, there were triggers, there were signs. Did you see them? It might have been, little Johnny lashed out in school, or somebody else did something really atrocious. Are there always signs for people who struggle with this disorder?
In this, for the individual who actually meet criteria, you will, because the very fact of diagnosis means that the person has to have had a history. So you'll already have seen. I mean, the problem is, of course, is that doesn't really link in to an individual who may have gone through 15 or 12 years of totally healthy environment, and then suddenly being traumatized, and then they're going to emerge, their problems may emerge then, or they may not. I mean, it's not inevitable that trauma will give rise to this type of increased aggression. Like you said, the individual who can regulate well won't show that form, and people, it's likely that your social context generally has an influence on how these things show.
I mean, it feels like always, like the whole what has the largest impact, the environment or the genetics, and I guess the question is really kind of convoluted because it's both, and it really it depends. So I'm thinking about the first group, but also the second group. They also have, the test picks up that they've had the 3 months and then the 12 months. So they all have to qualify at that least baseline.
In our studies, they'd have to be. That's again, the difference between actually the clinical environment and the research environment, and then of course somebody dealing with it, when the person hasn't met criteria because maybe they're beginning to escalate up, or maybe they're only 6 years old or 8 years old, or it's when we're really not sure how it's all going to be developing.
Of the groups that you're talking about, are they all able to, regardless of the fact that the relationships are not able to be cultivated in a healthy way always, are they able to get jobs and kind of function in a very minimal way? We get that they lash out occasionally, but are they able to be functional citizens in the society?
Oh yeah, I mean certainly. So what we see is actually with many of the children that we've had in the studies, it's not necessarily that they'll meet criteria for the entire time. The children stop having the diagnosis because of.
You can outgrow it?
You can be put in a new environment that means that the triggers aren't there. Again, it really depends on the group.
I see.
But the healthy group, they're very, very societally determined, very, very social environment determined. So the person may go to a new school even, and it's gone.
Wow.
The stressful, the hyperreactive group. Again, if the person's environment is much less threatening, much more mellow, then their problems may disappear. And even this deeply problematic callous unemotional group, again, if you put them in a different environment or, extremely vigorous parenting, where the parent is very involved in the child's behavior, knows what the child's doing a lot of the time, it may not cure the underlying problem, but it definitely can have a massive impact on how that underlying problem shows itself to the world. And so it's definitely not that you have these problems and everything's inevitably bad. Can
you change your brain?
So we are relatively confident that we should be able to, even with what's available, we should see changes. It hasn't been shown yet. That's one of the things that we're hoping to show in the next couple of.
It hasn't been.
It's been shown in other. So we know from work with depression and anxiety that you could do good cognitive therapies or good pharmacological
and really
therapies.
Change the chemical makeup of your brain.
Exactly, and how that brain's operating on a minute by minute basis, or certainly in the scanner you can see reduce. But nobody's shown that yet. With this population. That's stuff that's going on at the moment, and obviously be very important because indeed, there are people out there who say that you can never see change and all the rest of it. And if we can show very clearly, when we can see change and what groups particularly benefit from this change.
Because I'm thinking about the first group.
Well, the first group we may not see any change because it's actually,
it's not brain related.
Exactly.
Right.
So that group, what we'd be doing if say we had a good assessment battery, what we'd be doing with that group would just be saying, look, this group does not have anything.
Is that the bad group? Is
No.
this the are these? No, bad is not the right word.
No, I don't
But is
think.
that the group that is just responding to their environment and are acting out?
Well, not necessarily. I mean, I gave you that example with the book.
And I acted out.
Yeah, exactly.
Right,
I don't think you're a bad person.
Well, that's good.
I don't know.
That's
I don't know
good.
enough, but I'm
I got
assuming
you.
you're not a bad person.
Right.
And so,
I got you.
when I'm thinking about it, I think about it as a typically developing group.
Okay.
Given the social adversity that person may be facing.
Okay.
So I don't really aim my work towards that, because I think really the help that's going to be for that group is going to be at a community social level.
I got you.
Not at a therapist psychiatric
I
level.
see.
It's the other two groups that really fit more in with the sort of the medical psychology framework.
Wow.
And it's those two groups that I would be targeting sort
I
of
see.
interventions
I see.
with to help them hopefully.
So we have about another 30 seconds, not 30 minutes. Stop the press. So what parting words would you like to leave about how to deal with the cognitive emotional disorders, either for parents or for teachers, just sort of some general thoughts on how to help our audience deal with it?
So I think the really critical thing for me is this business to just stress the importance of emotion for these aspects of aggression, whether it's hyper emotional responses and this reactive temper tantrum type aggression, or whether it's reduced emotional responses and this sort of more callous, more goal directed use of aggression. I mean, being aggressive to achieve your goals. And the reason why I want to stress that is because when we start understanding that the problems faced by these different groups of individuals are emotional problems, it's suddenly much less, you suddenly think we can help people with emotional disorders. We should be able to help these individuals.
Thank you so much. Like, we could go on and on. It's so interesting. I would like to thank Dr. James Blair for being my guest. If you would like more information about the topics discussed on this program, you may contact Dr. Blair at the National Institute of Mental Health, NIMH, 9000 Rockville Pike, Building 15K, Room 206, Bethesda, Maryland, 20892, or email him at blairj@intra.nimh.nih.gov. I am Dr. Cislina Grosser Ledbetter. Thank you for watching.